Hi everyone, it's Dr. Oliver. We are going to talk about one of my favorite topics today, and that is palliative care. I made a couple of different PowerPoints because I'm not sure how familiar some of you are with palliative care. Since I was in school getting my nurse practitioner degree or certification, it has come leaps and bounds from where it was, 5, 6 years ago. I do still want to go over and just make sure that you understand what are the triggers for a palliative care consult and what does that palliative care consult do? I mean, what is that for? How does that help your patient? It's also important to understand the difference between hospice and palliative care. In this specific PowerPoint, we will talk about the differences between who is appropriate. There's a different kind of patient is appropriate for palliative care, and then a different type of patient is appropriate for hospice care. In a separate PowerPoint, I will go over more of the logistical differences between hospice and palliative care. So I've just included a couple of different definitions here of what palliative care is. Really, the World Health Organization has been a big promoter of palliative care, and so their definition of palliative care is that it is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. I love that definition because nowhere in there does it say that we are making death come quicker, as some patients say, or that we're handing out pain medication. And that is really a lot of what patients will think palliative care means. And so it's important that we as providers just take a moment and, one, understand all of the different emotions that our patients and their families are going through at that moment of time in order to actually get to that moment where a palliative care referral is made. And two, we have to understand that one of the biggest fears that people have in life is death. And, even just thinking of a conversation surrounding a person's death is very stressful to them. So they're going to have they're going to have preconceived ideas of what palliative care is, and it's our job to actively listen, but also direct that conversation to a more positive opinion of what palliative care is. So we need to educate them. Another thing that I love about this definition is that it talks about it having an impeccable assessment and treatment of not just pain, but other symptoms that people can have in their chronic disease. And that is one thing that really drew me to palliative care because it is not a black and white area of medicine. I mean, everybody is different. Every patient is different. They experience a disease differently than, Joe Smith that's sitting next to them in the chemo center. And it's important for providers to understand that. And then when we're actually treating those patients, it's also important to understand that sometimes we have to be creative. What works for this person here is not necessarily going to work for your patient. So sometimes with the medications, even though maybe a medication may not be listed as an FDA medication for that symptom, a lot of the times we play off of their side effects as well too to help relieve patient symptoms. And we'll go over that more because I'm going to do a whole section on pain management because there's a lot of different symptoms and things that I could cover in palliative care, but I think pain management will be something that you guys will really need to have a good understanding of, and we'll go over how you can be creative with that with these patients. So just a quick overview of palliative care. I know we've already kind of dived into this conversation, but it's important to know that palliative care is more of a designation of care. It's not necessarily a diagnosis. It goes back to that thing that we were talking about just a moment ago, that a lot of patients hear palliative care and they think that it means that they're dying. And that's not necessarily the case. What I always tell people is the day that we die, we are actually the day that we are born, we are chronically dying. And so inevitably, all of us at some point will die. Palliative care gives us an opportunity to choose how. Some people die suddenly in different accidents and things like that, and they don't have a choice. In this instance, when a person has a chronic disease and they are first initiating that palliative care referral, it is giving them a chance to take back some of that control that chronic disease has taken away from them. And so they are allowed to have a say in how the rest of their life, their end of life care will go. And that's important for them to understand. So the concept of palliative care was developed out of need, because really traditional medicine does not meet all the needs of our patients. And we talked about that a moment ago, where, a person with, or two people with the same chronic disease may not necessarily look the same, and they may not, they may not able to be treated the same as far as medications. So, this goes with the next bullet point there, where palliative care is a specialized medical care for people of all ages experiencing a debilitating or serious or chronic illness. And then I list some examples there, and those are some of my more common patients that I used to see. But we just have to recognize that everybody needs individualized care. Continuing on with that, palliative care also focuses on symptom management. And really, this was the fun part for me, because, you'd have these people come with, various complaints, and a lot of them, it's not just one. And I know you guys have patients like that too, that come in and it's a million complaints that they have. But a lot of these patients have seen a lot of other providers before you, and nothing has helped. And they're really looking towards you as kind of a last-ditch effort to find some sort of relief. And so you really have to be creative, and that is the challenging part of palliative care, but also the fun part. So palliative care uses a multidimensional assessment. So we are not just assessing their physical well-being, but we are assessing how are they doing psychologically, socially, and spiritually. So, I wish I still had an example of some of my palliative care notes, but if you have the chance to, if you are around palliative care providers, take a moment and look through their notes, because I'm telling you, they have the most detailed notes, and you will learn everything that you could ever imagine about your patient if they're doing it correctly. Because, not only was I treating people with medications, but I became their counselor. I was talking to them and, asking them how is their family doing with all of this as well. And how are they doing socially? Are they still seeing their friends? Is this patient able to go and be at church, because that's something that she enjoys to do? Those are all things that you are assessing as a part of that palliative care assessment. Palliative care is also very heavily focused on interdisciplinary teamwork. So it's actually a neat culture to be in, because everybody just really focuses on this teamwork type atmosphere if it's done correctly. So, I always had social workers that I was working with, nursing aides at times if they needed home health care, RNs that were, specialized to care for these palliative care patients. So they went through on-the-job training, physicians, pharmacists. We had specialized pharmacists that were certified in palliative care and hospice management. And it's really neat when you bring that whole team together, how much you learn from those people, but also to see how great care that the patient receives when everybody works together. So that's also a fun part. It also helps the patient have more control over their care by improving communication. And that goes back to what I said about how, it allows them to regain some sort of control back, because they're really, a lot of people feel that a chronic illness, when they receive that diagnosis, they feel like their life has been taken from them and they just have no control anymore. So that fear of dying becomes even more complicated by the stress of losing control. So really just having those conversations about those tough topics and helping them feel like they are regaining a sense of control back is really one of the greatest parts of palliative care for patients. These are some palliative care benefits. I won't read this slide entirely for you, but some of the things that I want you to just really focus in on is that palliative care affirms life. Dying is a normal process. It's something that is inevitable for everyone. So we're not necessarily bringing death on quicker, but we are recognizing it as a normal process, and we talk to people as such, and we help them come to terms with how at some point they will pass away as well. we integrate that psychological, that spiritual aspect of care. We always have chaplains on standby as well. And then another important thing to note with palliative care is that palliative care is not just for the patient, but it's also for the family as well. And a lot of good palliative care programs have like bereavement type services. Once a patient does pass away, then they have services that will continue on for the family, even though the patient won't be there. Again, palliative care uses that team approach, and it focuses on enhancing that quality of life for that patient. And I won't go on too much of a soapbox, but quality of life is different for everyone. It's very easy to think of what you define quality of life as, but it is very important to remember that at the end of the day, your opinion doesn't necessarily matter when it comes to a person's quality of life. It really has to be how they define it. And that's one of the first questions when I see a palliative care patient and I'm seeing them for a consult for the first time. That's one of my first questions is, what makes you happy? What makes you feel like you have purpose in this life? If everything else was gone, what is the one thing that you literally could not live without? And those are important questions to ask. A lot of people sometimes will not be able to answer that right at first, but that's why it's important to have those conversations, and then you can determine what that is. A lot of the times if people don't know, and through those conversations you help them determine what is important, what gives them purpose, it actually ends up being a really big relief for them, because maybe they weren't able to identify what that was before. These next couple of slides here, I just wanted to kind of highlight the differences between what patients will look like between palliative care and hospice care, and also kind of the differences in the care that they'll receive. So typically, if you look at a prognosis of a patient that has a chronic disease, for palliative care, they really need to have a greater than 6 months prognosis. Really, patients can be on palliative care even from the moment they're diagnosed with a chronic illness. This works out really well for cancer patients because we know that they're going to have probably some symptoms that they're going to have to deal with during their treatment, and it's nice if palliative care is already on board. The care is focused on supporting them so that they may live the best life that they can live with whatever time they have left. And that's despite there being a cure. We know there's not a cure with a lot of chronic illness. So we want to start talking about advanced directives. However, a lot of them are able to remain full code. And palliative care focuses on that holistic approach. It's very patient and family centered. Hospice care, however, typically they have a prognosis of less than 6 months of life, and the emphasis is more on end-of-life care. So we emphasize death as a normal part of life. There's typically not very many invasive or aggressive treatments unless they're needed to support that comfort that patient needs. Some hospices, people can get away with doing maybe one dialysis treatment a week rather than quitting it altogether. If we feel that it'll make them more uncomfortable if we quit altogether, but it just depends, and it depends on. It goes by patient. So there's a lot of paperwork that goes into that as well. Hospice care also focuses on a holistic approach. These next few ones, you'll see where palliative care and hospice kind of cross borders. Hospice care delivers palliative care, and I'm not sure if I said that earlier, but so hospice care is palliative care. However, palliative care is not hospice care, if that makes sense. So hospice care, it also relieves pain and other symptoms, just like palliative care does, and it improves the dignity of a person, or it promotes dignity. It improves comfort and quality of life. Palliative care and hospice care, you start having those conversations about realistic treatment goals. However, hospice care, it really starts focusing on that comfort. So it's kind of like when you come to a fork in a road, when both are on the same path, palliative care is really kind of on the same path. Where they start to break apart is palliative care gives some leeway for some aggressive treatment. We're starting to focus more on comfort care, and we're starting to focus more on, okay, we know this is a chronic disease. We know at some point death will come. However, we want to try to increase quality of life and have the best life that we can live. Hospice care is kind of like, well, this chronic disease has really started to progress. We've been slowly more so focusing on comfort care. However, now I'm at the point in my disease progression that we can let go of that aggressive curative type care and focus solely on the comfort care. So that's where they start to fork off from each other. So palliative care patients, like I said, it can be started early in the disease, and that is really ideal. It can go across all healthcare settings. I mean, we can see palliative care patients in assisted livings, SNFs, in the hospital. They can also remain on like a skilled Medicare type pay if their days are available, so they don't have to change a payer source. Hospice patients, however, it changes payer source, so we'll talk about that. It's more of a bundle program. Palliative care has not gotten there yet, although a lot of palliative care providers are trying to push for that. Care may be provided where the patient resides, so typically they do not get hospitalized, although we'll go over this later in another PowerPoint, but there are different levels, and that can include a hospitalization, but it depends on what the patient is experiencing in that moment. So to summarize some of the goals of palliative care, it seeks to promote quality of life, and that's for the patient and the family. It focuses on that mental, emotional, and spiritual well-being and comfort for the patient and family. It also seeks to optimize patient dignity and just overall patient function. We want them to be able to enjoy what life they have, and that's important, I think, for anybody. I think anybody would want that. We also want to help them achieve and maintain the fullest relief of their pain or their other symptoms, whatever is ailing them. We want to try to achieve some sort of relief from that. So these are just some examples of patients that could be on palliative care, and I will tell you, I saw children on palliative care as well and on hospice, and palliative care in general is not for the faint of heart because it is very emotionally and mentally taxing sometimes. Like I said, how it was challenging sometimes and you had to be creative to find things that would work for patient symptoms. That is the fun part, but it is also very exhausting sometimes because sometimes you have to make a lot of phone calls to pharmacies, to insurances to try to get things approved. And when you start seeing children, it is a whole nother ball game even more. So, you invest a lot in these patients, and you do get very close to them because you have to know a lot about them in order to treat them appropriately. The children sometimes were even harder because, they haven't even lived a full life yet, and they're having to deal with this chronic illness, and their families are going through a lot of emotions. And so, anybody that goes into palliative care, I would definitely encourage you to do so. But it is important to, before going into it, that that there's going to be moments where you just need to kind of take a step back and take some time for yourself because it can be a little overwhelming at times. So some of these diseases here, so adults or children with congenital injuries or conditions that led to a life of dependence on life-sustaining treatment. So this can be congenital heart disease, Down syndrome, patients of any age with acute, serious, or life-threatening illnesses where a cure or reversibility is not a realistic goal. So like a severe trauma or leukemia, acute CVA. So these type of illnesses, these chronic illnesses, result in a significant burden and poor quality of life. Here's a couple more examples. People living with a progressive condition, and this was the majority of my palliative care patients. So neurodegenerative disorders, dementia, malignancy, liver, renal failure, all of those. I mean, I saw many patients with those. And then people living with chronic and life-limiting injuries from accidents or trauma. I used to get a lot of TBIs, and TBIs sometimes can be very hard to treat. That's a whole nother lesson, I feel like, for palliative care. But I did get a lot of those. And last one, so seriously and terminally ill patients who are unlikely to recover or stabilize and who really require intense palliative care. These are hospice candidates maybe who just don't want hospice, or maybe they just are just shy of being appropriate for hospice. These would be definitely appropriate consults for palliative care. So this slide and the next one, these are what I call palliative care triggers. So these are things that would, if you see these on, on your patient, so your patient meets these criteria, these are things that should prompt a provider or a family member or a patient to maybe consider a palliative care referral. So they have greater than a 6-month prognosis. They've had greater than 3 hospital admissions in 6 months. I'm sure you guys are probably thinking of a lot of patients in your mind right now. I know I do every time I read this. Increased prolonged hospital emergency room department visits, metastatic cancer, incurable cancers, weight loss greater than 10% over 6 months, multiple chronic illnesses, a decline in functional status, complex care needs. Continuing on, people that need aggressive symptom management to enhance their quality of life, or maybe people that have difficulty or really the inability to take any meds or oral intake, semi-comatose states, any lack of progress in therapy and they're just not getting better. Again, chronic respiratory failure, people with lung disease, my goodness, I saw so many of them. So they are always, if they are in a progressed state, they're going to be appropriate for palliative care. Low O2, SAD at rest, or patients that have no advanced directives or DNR with the above triggers, and maybe they just need somebody that will be willing to have that conversation with them and provide that education on why it's important. Now, this last slide here I included because I wanted you to see the difference between the palliative care triggers and the hospice triggers. And again, I will have another PowerPoint that goes in a little bit deeper with the difference between hospice and palliative care, but hospice, the triggers for hospice is less than 6 months prognosis. So metastatic cancer that's not responding to any form of treatment, liver disease that's end-stage cirrhosis, and I will tell you a lot of those patients, they will look like they are on death's doorstep and you know that they're ready to be on hospice. Renal disease that maybe is not responsive or not able to tolerate dialysis, stroke patients that require a lot of aggressive care to even keep them alive, inability to maintain any oral intake, a failure to thrive despite aggressive treatment, and then any of the end-stage CHF, COPD, or other appropriate diagnosis. Now, just because a person has these triggers doesn't mean that they will necessarily automatically be appropriate for hospice. So hospice has to go through their own assessment, and they have to basically, there's a way to document. It's called a face-to-face, but they have to be seen by a provider, or so a physician, an MP, or a PA, and they have to meet those criteria, and it has to be documented appropriately. Palliative care is a little bit more lenient because Medicare isn't as strict with palliative care, although I can foresee in the future that will change. But hospice has a lot of hoops that you have to go through in order to make sure that a person is appropriate for hospice, just because people have abused that system in the past. So it's just important that people understand that it never hurts to have a hospice or a palliative care referral, though, and that's usually what I tell people. At least at the end of it, you should have a little bit more information about your disease progress, and and also just some things to think about for the future as far as decisions on advanced directives and end-of-life care.